Next Friday is the beginning of Breast Cancer Awareness Month. Research shows that early detection truly is the best defense against breast cancer, but still, around 300,000 women will still receive that life-changing diagnosis. Treatments range from chemotherapy to surgery, but for many women, the idea of undergoing a mastectomy seems too much to think about, unthinkable. Here to talk about all of that, Doctors Heather Richardson and Dr. Elise Cassileth, who are from the Bedford Breast Center. Ladies, I'm so glad that you're here with me to talk about it. Let's talk first, if we can start with treatment, because we know, Dr. Richardson, you treat breast cancer. Dr. Cassileth, you are more about the reconstruction. You know, it's really interesting. We've seen the guidelines shifting, Dr. Richardson, a lot, and I think there's still lingering confusion about when a woman should be going. What are you telling your patients about when they should be going for their annual mammograms?
All of the major physician organizations have agreed that we want women to start at 40. Annual mammograms at 40. We want women to be comfortable with their breasts and doing self-breast exam. You should talk to your doctor in your 20s and 30s if you have a family history and may need to start screening a little bit earlier. And we also want especially younger women to know that they should know if they have dense breasts, because we might want to add additional imaging like ultrasound or maybe even MRI. The American College of Radiology notes that if sometimes we skip on those guidelines, we may be missing somewhere between 6,500 and 10,000 breast cancers a year.
Oh my God. Dense breasts, one thing to be aware of. What other red flags, signals, things that we should be on the lookout?
Family history, of course, if you have, whether it's your mother's side or father's side, it doesn't matter. If you have relatives with breast and ovarian cancer, if you're a person of color, if you have Ashkenazi Jewish heritage, we definitely want to make sure that you are looking into risk screening and making sure that your doctor feels comfortable with whatever screening plan that you might need. You might need a little bit more screening, especially if you're one of those people that have a higher risk of more lethal cancers at a younger age.
And let's be honest, let's just talk about the fact that we have to be good about being our own best advocate, right? The self-screening and examination. Just a reminder, ladies, a good time to do it is in the shower, or etc. So, Dr. Cassileth, I want to bring you in and talk, and both of you, let's talk about the fact that we are at a time when there have been a lot of advancements. This is not the era of our grandmothers or even our mothers. There's so many new technologies and many new advancements. And even in terms of reconstructive surgery, you're having great success.
Yes, I mean, the changes that we've made over the last 10 years have been just profound. So, you know, we all think of what we know about mastectomy is that you get a big cut across your chest wall. That's, you know, old mastectomy technology. What we do now, and what centers hopefully are all coming up to over the next 5 years, is making the incision actually under the breast, like almost like an augmentation, sparing not just the skin, but the nipple itself. So now you actually have a full breast skin that looks normal, and then going directly to an implant or natural tissue reconstruction. So now when you wake up from surgery, you actually have a normal looking breast. So, you know, it's so different from the way we used to do it with a big cut. We used to do something called a tissue expander that went in there and took months to kind of blow up. It was kind of, you know, brutal. And when I look back and think, gosh, you know, what people have today is what you would think would happen. Hey, let's take out the breast tissue and just put something in there that looks just like a breast. That's, of course, what we do now. And another new advance is, you know, that used to be numb skin. We're actually reconnecting the nerve that's cut during the mastectomy to a target next to the nipple, so people can actually have sensation after mastectomy.
So not only does it look like your breast looked like before, it feels for you, or dare I even say somebody else who might be, you know, spending time with it. Right, I'm just saying. And that is part, and I can imagine, Dr. Richardson, in terms of getting women to come and get treatment, if you don't have that fear, right, that you're going to feel like Frankenstein at the end of it. If you have that taken away, you might be more willing to come for the screening and be your own sort of best advocate.
Absolutely. You know, treatments for breast cancer are better than they've ever been, and they keep getting better. Cure rates are going up, up, up. And so to be on this side of surgery and to know that things are so much better and that women come in and a lot of times looking better than they did. Not that anybody would want to go through this process in order to look more youthful or perkier, but it's a really good feeling, you know, when I see our patients come in healthy and happy and feeling great when they want to be in the locker room at the gym, or whether they want to wear a nice dress. They feel comfortable, they feel beautiful, they feel sexy, and that's what we want for all women. And we want women to know that.
Look, we recognize our male counterparts and the males in our field, but do you think it might have taken women saying, look, we are surgeons, but we also understand what it is like to be a woman, and we need to have this be better. We need to have technology working to help us make this whole experience much better, not because we've got it survivable. You can survive breast cancer, but the people that survive with it don't need to walk with this weight on them forever.
I mean, that's just very well said. And it's not just us advocating for our patients, but also there's this whole now generation of patients coming up in the world that they research. A lot of people have genetic predisposition for breast cancer. So they're also out there. Why can't I keep my nipples after a mastectomy? Why can't I have this little incision?
Right.
Why do I have to look deformed? So they're actually the ones bringing the standard of care up and raising the bar with us, because you know, we can't do every mastectomy or reconstruction in the country. So those people are changing things for women around the country, getting them better surgery, better outcomes, better appearance. And especially if you can imagine, if you're having a prophylactic mastectomy, meaning you're doing it to prevent disease because you have a genetic predisposition, you know, of, let's say, an 80% risk of cancer, you're not going to settle for some emergency mastectomy. You're going to want to look good, and you know, we can do that. And
you
then
can do it on your terms.
Yeah, you can do it on your terms, and that is the key right there. Look, I want to say a big thank you to the both of you, Doctors Heather Richardson and Dr. Lisa Cassileth from the Bedford Breast Center. We're going to have more conversations like this, obviously through October, Breast Cancer Awareness Month, but we wanted to kind of get a jump on it with the two of you. Thank you so much for joining us today.
Thank you.
Thank you so much.
Delight.